I will be briefly discussing primary adrenal insufficiency today. By the end of this video, I hope that you can walk away with some key features of PAI, including signs and symptoms, physical examination findings, diagnostic criteria, and treatment. It's not a very common condition, so the goal of this video is to highlight features that may help you to keep PAI in your differentials as well as pass your boards. Also, keep in mind that primary adrenal insufficiency is when the insufficiency is primarily at the adrenals. Secondary insufficiency is when the insufficiency is secondary to the pituitary and the pituitary gland is not producing any or enough ACTH. Primary adrenal insufficiency is caused by low steroid levels of both glucocorticoids, like cortisol, and mineralocorticoids, like aldosterone. Common causes of PAI include abruptly discontinuing exogenous steroids, autoimmune disorders like Addison's disease, genetics, especially if the adrenal insufficiency is found in children, and infections such as HIV, tuberculosis, and fungal infections. Symptoms are usually vague, like, I'm just having this abdominal pain that won't go away. So most patients will end up going to the doctor 3 or more times for the same thing before they are appropriately diagnosed. Since only 1 out of 8,000 patients have PAI and the symptoms can be so vague, this diagnosis is quite common. Signs and symptoms may include decreased appetite, nausea and vomiting, nonspecific abdominal discomforts, generally tired, salt cravings, amenorrhea. Physical exam findings may include weight loss, bronze skin tone, which will not be apparent if your patients have darker skin tones, so just be aware, and armpit and pubic hair loss. Diagnosis is made with ACTH stimulation test. Baseline cortisol and aldosterone levels are drawn. If both levels are low, then 250 micrograms of ACTH is injected into the patient. This is an extremely significant amount compared to the pituitary's natural ACTH quantities released. A positive diagnostic test is persistently low cortisol and aldosterone levels despite being flooded with the steroid-stimulating hormone ACTH. In secondary adrenal insufficiency, serum ACTH levels will be low, and adding ACTH will result in an increase in the cortisol and aldosterone. Since the dysfunction is not at the adrenals, rather the dysfunction is secondary to the pituitary. Since PAI patients are low in both glucocorticoids, like cortisol, and mineralocorticoids, like aldosterone, treatment is replacement with hydrocortisone and fludrocortisone, respectively. These steroids are typically supplemented by a steroid prescription on an outpatient basis. If steroid levels get too low, patients may have signs and symptoms of an adrenal crisis, such as abdominal pain suggestive of an acute surgical abdomen, extreme hypotension, tachycardia, altered mental status, and severe hyponatremia. In the case of an adrenal crisis, IV or IM hydrocortisone is appropriate treatment along with IV fluids for 24 hours. So we know too little of the steroids can cause adrenal crisis, which can be a life-threatening condition, but too much of the steroids is bad for you too. Excess cortisol can cause something called Cushing's syndrome, with clinical features such as a buffalo hump, moon face, stretch marks, weight gain, hypertension, and hyperglycemia. So it's extremely important for adrenal insufficiency patients to take steroids as prescribed. Lastly, I would like to point out that as prescribed also means to not take steroids not prescribed. If someone takes exogenous steroids without an indication or abruptly stops, this could also put that someone into Cushing's syndrome or adrenal crisis, respectively. This concludes this quick overview of primary adrenal insufficiency, and I hope you are able to take away some key features of PAI after watching. Thank you.